My name is Christina Sparrow. I'm a Black woman in my 50s. I'm wearing a head wrap and glasses, and I identify as she, her.
My name is John Johnson. I am a African American male in my 60s. I have a black t-shirt on that says Brothers Like Us, and looking forward to this discussion.
My name is Ewan Ben. I'm a Chinese woman in my 30s, and I have black hair. I'm wearing a light brown shirt with black dots on them. Yeah, and I'm also very excited to have this conversation.
And my name is Miguel Ramos. I am a Hispanic male. I am wearing a white collar shirt, gold tie, and I'm really excited to be here. So, Miguel Ramos, I have 20 plus years in various human services experience. I've worked with individuals with various forms of disabilities, more children. I've worked with adults that have been the abuser in intimate partner violence. So the abusive partner intervention. I've worked and supported survivors of domestic violence. I've assisted families uh, learn parenting skills, what's called parenting journey, teens that are about to become parents, and that dynamic, working with them. I've worked with individuals within with anger management, whether it was mandated or they self um, disclosed and chose to want to go into that and work on themselves. With healthy families is primarily with individuals that were being released from being incarcerated and they wanted to reintegrate one way or another with their families if they could, or at the very least, develop a relationship where they can maybe not go and live in the same home, but at the very least reestablish some sort of a relationship with their family, as well as a social resilience model, which has been with individuals who have experienced some level of trauma and how they can regulate and notice what's going on inside of them so that they can process either releasing distress or identifying what's going on so they'll know that, yes, this is something I can work on and I can do, or I need further assistance and help. The Narcan training, of course, for those individuals that um, either have friends or family members or just want training on how to use Narcan, as well as those individuals that are abusing substances and they need to carry a Narcan kit on them in the event that they see someone overdosing, they can apply it, or God forbid, they themselves are overdosing. Somebody can go in their pocket, grab it, and reverse the overdose. I am also a mental health first aid certified instructor and trained by the city of New York. And I have done quite a few trainings with mental health first aid for adults, youth, seniors, veterans. I myself am a veteran. Also for the Spanish community, especially with a lot of migrants that are coming into the city. I know a lot of individuals focus only on the Hispanic migrants that are coming in, but there are a lot of migrants from many other countries that you don't see or hear that they're being announced in the news. They're not making the headlines, but a lot of things are happening to them as well. And a lot of things that they went through to be able to come here to find out that now they're living in terror. So in those areas, those are my expertise. A lot of the cases that I do get for the individuals that cause harm in intimate partner violence, they're court mandated. And that's part of an ATI. In other words, they either take the program, if the judge orders them, takes the program, or they can be incarcerated. It's an option. And you have those that'll say, no, Mr. Ramos, thank you. I would rather, go up north and it's okay. And I tell them it's okay. but then, it's an alternative rather than incarcerating someone for whatever situation. And it depends case by case. And with that, I guess I'm checked in.
Yeah. Yeah. In the interest of being brief, I'm just really just give you a quick summation of who I am. My name is John, as I said, John Johnson. I'm a New York City resident, and I've had a bunch of jobs from working with youth services, from director of a Boys and Girls Club to teaching in every borough of New York City. And after that, I worked with Bill Clinton and his first stint as president, and I also worked with Jesse Jackson. But my main focus now is working with people that live with mental health challenges. I indeed am a peer. I was diagnosed with a mental health challenge a long time ago. I'm not going to say how long, but I've been living, I think, successfully with the diagnosis. And I began working with NAMI about 7 years ago. NAMI is the National Alliance on Mental Illness. And I've done a bunch of work with them, from In Our Own Voice, which is where I go to schools and I tell my story, and I kind of share with students about killing the stigma, also ending the silence I do, and also a program I'm doing now in the Black and Brown community is called Sharing Hope, which I call a community conversation, where I go in and open up the conversation about mental health and mental illness, and just get the discussion going. And it's a 3-part series where I tell my story. The second one, we bring in a clinician. The third part, we give out resources to the community. So that's kind of a quick synopsis of who I am and what I've done. Looking forward to the questions that are going to be posed.
I guess I'll go. Hello, my name is Ewan Ban, and I came to the United States when I was 17, so I can say I'm an immigrant. And I'm always confused about if I'm like the immigrant or first generation, probably like half generation. So I was always interested in psychology, so then I studied, and then I became a licensed mental health counselor. And a school counselor at the same time, because I studied both. And then my first job was being a school counselor at the Flushing International High School. So in those 3 years, being a school counselor in a lower socioeconomical level school, and with not many, all students were recent immigrants, because our school only take immigrant students who are in the United States for less than 4 years, and regardless of documentation status. So I witnessed a lot of trauma and a lot of just unawareness from the kid themselves and from the parents in mental health. Like, mental health is kind of the last thing in their mind, which I don't blame them, because if you're trying to survive, you're trying to put meals on the table, you really cannot care too much about, how you're feeling. So I supported students through counseling, through running groups, through outreach, through doing advocacy for them during those 3 years as a school counselor. And after that, I feel my true passion is still with doing mental health counseling, doing therapy. So then I became a therapist with a psychiatrist. Like in a psychiatric clinic in Queens. And in those 3 years as a therapist, I worked a lot with also new Chinese immigrants, but I also had the experience of working with a wide range of diagnoses. They range from, let's say, mild depression to very severe psychosis. So I accumulated a lot of experiences there, and really saw the huge need in the immigrant community for mental health, and the lack of awareness too. Like that, I think I will mention that many times today later, because it's just the lack of awareness is really huge, and I feel that will make all the difference if we can change that. So then, after being a community therapist for another 3 years, then I became a solo therapist myself. Then quickly, I founded Riverbank Psychotherapy in New York. So now we're in group practice. We now have 4 therapists. We are all Chinese. We're all Chinese Mandarin speaking, and we mostly support college students, primarily Asian and Chinese, and also some young professionals who were college students and who just got their first job in this new country. So now the main diagnosis I work with would be like perfectionism, trauma with family members, a lot of anxiety and depression. So that's my main work now, but with college students and young adults. So that's my introduction.
So this is Christina Sparrow. So I'm a certified public accountant by profession, um, and a mental health advocate, and I live with bipolar disorder. I'm the founder of New York City Mental Health Collective, a grassroots organization that is raising awareness on mental health to normalize it in New York City. Too often, people look at people who live with mental health conditions as dangerous. And for a fact, I know I'm not dangerous. I'm just a human being who has issues, just like anybody has issues. And I'm working to normalize it and to raise awareness for people to get help of all backgrounds because mental health is in all of us. As the New York City Mental Health Collective, I had my second mental health Mayo Town Hall, which was very successful, and I'm happy. I'm also the founder of the Person-Centered Intervention Training Response Program. It's a non-police, peer-run crisis response program where peers respectfully engage with people who are well, who are becoming unwell or in crisis to divert them from incarceration or like over hospitalization. It's important that we have peers who are experts in this space to be able to talk to people who look, walk, and talk like us because it's like we're just people. And so I also trained in the CIT training, which is crisis intervention training, where I trained law enforcement officers on best practices and de-escalations and crisis communications when dealing with people in crisis. And I think that kind of sums it up. So our first question is, how do race, ethnicity, gender, or social economic status further complicate the intersections of mental health and disability? I'll take that question. So this is a critical question because race, gender, social economic status, and disability intersects the shapes of mental health experience, especially for Black people and Black women in our communities. Black people face systemic barriers in mental health care, such as misdiagnosis, stigma, lack of access to culturally competent providers. When disability is added to the picture, the challenges are magnified. Disabled Black people or often encounter both racism and ableism, which can lead to being misunderstood, underserved, or even criminalized in public systems such as healthcare, housing, employment, education, and law enforcement. For Black women in particular, it's even more layered. We are often the caretakers, the emotionally strong person, self-sacrificing ourselves, and we're labeled the strong Black woman. And if we come up too strong, we're labeled the angry Black woman, which we're not. We're just going through a lot of pressure, and we're definitely misunderstood. And for that reason, we don't always get treatment and help because it leads to underdiagnosis and inadequate care because people are telling us to be strong. And so we're trying to internalize it and to stay strong. And if we can't care for the role, and also when we think about poverty, many of us people in our color, we live in poverty, so we don't have access. We have limited access to mental health services when not in communities. Sometimes the services are outside. You have like health deserts where you may have to travel a bus to the train to get to some places and you won't be able to have access to it, or even bring even a daycare. Who's going to provide services for my child if I can't get the help? What am I going to do? Um, so when we talk about mental health and disability in African American communities, we have to use the intersectional lens. It's not just about the individual care, it's about transforming the systems themselves to make it more equitable, inclusive, and rooted in the real experience of people they serve.
So when I first see this question, the first thing that popped in my head is just the one thing a lot of Chinese psychiatrists who told me when I was a new therapist, which is when Chinese clients, patients come to us, they're already very severe and more severe than maybe other populations, I imagine, from what they told me. I think my guess of why is just in the Chinese community, the awareness is so low. Like when people may be just showing some depression, some anxiety, maybe even some mild hallucinations, like people or family members tend to brush it off and trying to say, oh, it's just a mild illness, it's a phase. And then they don't get any treatment, they just zero awareness, and then hopefully will just go away without just seeing it, and then they become very severe. Like one extreme case I had when I was working for a psychiatrist was that we had one patient who had pretty severe psychosis, like hallucinations, audio hallucinations, a lot of delusions. But his parents were still trying very hard to put him to work in restaurants, make him find a wife, to marry, have kids. But basically, the traditional Chinese mindset is that if you seem to be abnormal and we put you into the mold, the track of a normal person, then you're fine. So it's so extreme that they really kind of got blind of the person's clear illness, and so that's very heartbroken for me to see, and so that's the first thing I'm thinking. It just for the Chinese community, it's very hard for people to actually get care unless they're very, very severe. And another thing I can say is that in my later when I did private practice, I slowly would have some male clients and man clients from like more maybe higher socioeconomical status, and I noticed that it's not just the socioeconomic status that would make it hard for people to seek help. Gender is a big thing too, and in psychotherapy though, in mental health, I think being a man probably makes it harder than a woman to seek help. And I look forward to hearing from Miguel and John from the male perspective, because as a therapist, I noticed that or I can only speak for the Chinese community. The Chinese community, I know for Chinese men, it was expected culturally, like in the traditional sense, that a man needs to be super collected and very strong and basically not emotional. But psychotherapy is all about emotional and all about the wounds we have, the trauma we have. And men are not allowed to talk about it. So, and it will be seen as weak and just bad, and again abnormal, these kind of like negative terms if a man seeks therapy. So I feel particularly for Chinese men to seek therapy, it's also very difficult. And the last thing I want to say is because we work with a lot of university insurances, so we get a lot of college students. And in college students, especially Chinese college students population, oftentimes I witness this very unique internal conflict these students confront when they have to apply for accommodations. When they have, let's say, ADHD or anxiety or depression, one part of them wants to apply for it because it will help them, help their grades, help their mental health, they're less pressured. But on the other part of them doesn't want to apply because for them, apply for it means I'm abnormal, I'm crazy, I'm weak, I'm less than, right? All of those shameful stigma. So so that's a common internal conflict Asian students face when they want to apply for accommodation. So yeah, so these are the things I see a lot in my work experiences, and I just want to say, like in summary, I would say all of these things: race, ethnicity, gender, and especially socioeconomic status. All of these things really, really make it hard for people to seek mental health help. But we all deserve some help.
This is John speaking. All those things that are all determinants of society, right? Socioeconomics, gender, race. Did you realize that when a slave wanted to be free, that was considered a mental illness, right? So
Mm.
we have to think about why Black folks don't want to go. And although that's way back, but there's a certain kind of fear or because Black folks don't want to go to white doctors who are determining certain things, right? In terms of socioeconomics, when a person is acting erratic in an affluent white community, right? What happens is who they call the hospital, but in a Black community, who they call the police. So that is a disparity, and then the whole agenda, how this is that, the whole idea of prenatal care and stuff like that in the Black community. There's a disparity. So there's a lot of things that affect uh, mental health and the determinants that we have of our sociology. So a lot of all those things come into play when it comes to our mental health and our mental wellness. So I'll just kick it to you, Miguel.
And this is Miguel speaking. I fully agree with what the panel is saying. Language is primary just because of the way people associate the language and internalize certain languages and certain things that are said, they won't seek the help. An example, at a very young age, I'm not sure how everyone here has I even heard it, but at a very young age, a boy is taught boys don't cry,
Mhm.
girls cry, boys don't do this. So at a very young age, you're teaching them to be desensitized to their emotions, their feelings, and that impacts them as they're getting older and going into adulthood. And it really impacts their relationships. But certain race, for instance, in a lot of Spanish cultures, they don't speak about, especially the men, they don't speak about mental health. It is absolutely a sign of weakness. I'm expected to be a provider. I'm expected to always hold it together. I'm expected to always know everything that's going on. I'm expected to work 80 hours a week, come home, and still do everything I have to do. I'm expected to know it all. I cannot be vulnerable. I cannot be weak. I cannot. And once again, all that does is create a chaos inside of a person that finally, if it gets released, it'll get released in a negative way. And instead of having those that are showing up to assist you, they're showing up and they're then adding trauma onto the issues that you already have because they don't understand. They don't get it. Um, I know that it was spoken about how women tend to be more emotionally intelligent than men. Men are trying to get there. They are trying to find a way to be able to become emotionally intelligent and erase everything that they were taught about. Hold your emotions, don't cry, don't let it out. Don't. It is extremely hard. It is extremely hard because then what if I have my partner? Here I am trying to emotionally and mentally heal and discharge things that are inside of me. And now I find that my own partner is looking at me like, what's wrong with you? Are you weak? Why are you sharing so much? Why are you? And then they re-internalize, and it's easier to walk on eggshells. It's easier to walk in silence. It's easier to hold it in, get stressed, and have a heart attack because I didn't know how to speak. I didn't know how to discharge. And if I can't speak to my partner, I really don't want to speak to a clinician, someone I don't know. And if it's somebody that it's in my race and I really don't want to speak. I know that John spoke about how some people will go to someone who they'll go to a white doctor. Some individuals will prefer the white doctor thinking they're better educated
Mm.
rather than going to someone in my culture that understands me, that understands what I believe, that understands my religion can be another reason that can stop somebody from seeking the help that they need. Why? I'm not demon possessed. Why? I don't have spirits. Why? Just because I believe certain things does not mean that I don't have a connection with my higher power. But it may be looked upon that way. And it's then if your family looks at it some type of way where if they find out that you're getting services, whether male or female, even if you're at parties, you're that uncle, that brother, that sister that is isolated. You're amongst the group of people, but you're still isolated. You're alone. They don't want to approach you because, oh, that's the one getting mental health services. They must be a little crazy. And they just add on to the stigma. So I would rather walk around with everything that I'm carrying in my heart and inside of me, regardless of how it destroys me, then get help, and then God forbid one of my family members or neighbors find out about it, or my religious organization. It is so hard. It is so hard to go and seek help. As I said, there are more men receiving the help, but not by far as many as they should be. Because even when they go in to finally see somebody, the clinician will say they're holding back. They're giving me bits and pieces, and then they just pull everything back. And of course, then there are those that can't afford the service. They'll have insurance that'll tell them you're only authorized for 8 sessions. 8 sessions, you're barely doing an intake or an assessment. So yeah, there are many factors.
Dag, all of this stuff resonates with me. So it's like when you think about like the mental health stigma in our communities, particularly Black communities, I think like when John was talking about it, it's rooted like through slavery and like racism. We go back to like even the Tuskegee studies when they were using Black men for the syphilis studies, and it's like they're thinking they're getting treatment, but they're actually being ex as experiment. And it's just like when you think about even Black women, their bodies are being used to like um as experiments when we're going through a lot of pain through birth and we're not getting like the medication as they give to other folks. And so it's just that on all of that trauma causes this mental health, it's this trauma on top of trauma. And when we walk out the door, people see us as Black. So you could be very happy in your home, but once you walk out that door, we're just Black. I can't say that I could pretend to be white, or I could pretend to be another race. I'm just Black. So if people are racist, they're just going to be racist, and I'm not going to be treated the same, and that causes more emotional harm in me. And also, a lot of times in our community, I know we mentioned earlier, people are misdiagnosed. Was it drapetomania? I think you were mentioning, John, about the slaves running away. That's a mental illness, which is so unfair. Um, an ongoing misdiagnosis and mistreatment is not about the reluctance of getting here. It's structural racism. Where and why, where did we go to get the support? Because we're afraid. In this country, I looked it up, it was only 2% of Black psychiatrists in the United States. We got 13% of Black people here. So where are we going to get our treatment from? So we're going to get a treatment from people mainly outside of our race who may not even know what we think, walk, talk, and think like and have similar experiences. And so, like, if I'm going to a doctor and I'm like raising my hand, I talk this way, they're gonna be like, oh, well, Christina's aggressive. No, Christina's not aggressive. This is the way she talks is part of her culture, right? And the same thing, it's like, this is why we don't feel safe and supported because no one sees us, validates us, right? And I know even Miguel, you talked about the religion, right? We're taught, like, we taught in the family to pray on it, stay in the house. Even the Black families, don't tell all people what stays in the house stays in the house. And if you go to if you practice certain religions, like, where, I mean, I'm not judging any religion, right? But some people like use sacrifices of animals or whatever, and that's just their religion, right? Or they're speaking in tongue, right? And that's like, I grew up in Pentecostal. If I go to a doctor's office speaking in tongue, they're going to medicate me with all types of stuff and not understand this is my culture, this is my religion. So now I'm being overdiagnosed, medicated because of my religion. And if even for Black women, it's like we're the backbones of the family. We're holding our men down, we're holding the kids down. It's a lot of pressure on us. And it's so hard to ask for help because it's like we have to, because of the way the system's designed, we're supposed to suffer in silence. Period. Period. And so even when we go to our healthcare professionals, it's like we're dismissed. We experience more trauma from our clinicians sometimes, and it's just really unfair. It's just not a very fair system. So breaking the stigma means like creating a space where Black women could be heard and not feel the judgment. This is how you break the stigma, is making sure that wherever we go, we feel heard, validated, so we can go get the help.
So the second question is, how does mental health stigma differ across communities? And I'm the first one, so I'll go. As I was hearing all your sharings, actually a new thing came to my mind about mental health stigma. It, like, besides all the stigma we're already talking about, I feel there's this also hidden stigma in especially our minority communities, the communities that aren't very comfortable or have a lot of awareness of mental health or psychotherapy. And I think the stigma is I cannot trust the therapist or the psychiatrist that much, especially if they look like me, because the shame, the stigma, right? Our traditional cultures, it is so looked down upon. It is such a taboo. It's such a bad thing. I noticed some of my female Chinese clients, they insist and they're from China too. Like their first language is Mandarin, and they insist on speaking only English to me. And there are probably plenty of people who purposely did not choose me because I look Chinese just like them. Because maybe me as a Chinese woman represents all of that judgment, like all the hating, all this criticizing, all of those things. Maybe their moms or the environment give to them. So yeah, that's another very hidden stigma I just realized, and that's another kind of roadblock that prevents people from seeking help. Because you're in the wing, right? I cannot get a Chinese therapist, I also do not think a white therapist understand me. Then who do I left with? No one. So I think that's a big roadblock. And another thing I can talk about is since we're talking about cross communities, the stigma, I want to make a distinction between within the Chinese community, the new immigrants versus the Chinese Americans. Because in my experience, I noticed that these two groups may have very different views regarding mental health. I would say in general, of course, there are individual differences, but I want to say in general, I saw that more Chinese Americans, like people who are born and raised in America, would maybe share more the similar values and the similar level of stigma as the majority of people here. But Chinese immigrants, and it doesn't matter how many years they're in the United States, I feel many of them still hold the very traditional values they carry here from the home country. So it's much more likely for a Chinese immigrant to feel, oh, you're seeking therapy, you must be crazy, you must be insane, or that is a weird thing to say, right? Whereas let's say you're in the community of everybody's Asian American, then you can say, oh, I just talked to my therapist, and then there's no looks or weird remarks. But you may get those or you may not even want to say it in the more traditional immigrant community, because you will then get not great treatments. So yeah, so I just want to make that one distinction. Then John?
So yeah, I think stigma is probably one of the biggest deterrents of why people don't get help. I'll just give a quick example. I was the director of one of the directors of a Boys and Girls Club, and we had one of the top Boys and Girls Clubs in the country. And I was working at 4 years, stellar reputation, everything. And then I started doing work with NAMI, and I decided to kind of come out to my bosses and say, hey, I'm doing work with NAMI, and I'm telling my story about living with bipolar. And when I say there was a drastic difference about the way people viewed me before I told them and after. Now, I was the same John, stellar reputation, but little things started happening. Like, if I reprimanded a kid, some of the kind of, oh, is he having a bipolar moment? Or, so they started thinking differently. So therefore, people don't want to come out and say, because of that stigma, there's going to be all kinds of things that are not necessarily true. But so they say, you know what, I'm going to stay underground. I'm not going to tell anybody. But the good thing is now, and I think Miguel talked about a little bit, that people are now coming out more, and it's becoming better. and the stigma is a little less. That when we have celebrities coming out talking about living with mental health challenges, and people, especially after COVID, people started really taking stock in their mental health, saying, wait, what's happening with me? What's happening? And that's a good thing. Kids are now talking. I go into schools, and now we're talking about mental health at an early age. I go into second grade class, and they want me to talk about mental health. You say, well, what do I say? So I say things like, uh, who here has ever been sad? Who have ever been happy? And we talk about emotions and feelings now, which is good because now that stigma, and we're learning how to care about our brothers and sisters instead of stigmatizing them, and that's a good thing. So, the more people that talk about it, and I think that goes to one of the questions that we have, but more people that talk about that stigma is dropping a little bit, but it's still there. And even if it's not outward, it's not overt, but it's people say, "Whoa," if I tell someone that I live with, and I always say I live with the diagnosis of bipolar. I'm not bipolar because that's a diagnosis, right? No one ever says that they're cancer or that they're diabetes. But once you tell someone that, of course, it's never a positive thing. They say, "Oh, John, I got bipolar." Yeah, yeah, yeah. It's usually like, "Whoa, he's gonna kill his whole family." He's talking on the street. There's more people that look like me that live with a mental health challenge than that person. But the media, I'm not sexy. The media portrays those people, and I'm not saying that that doesn't exist, but there are more people that look like me and are doing very well, and although we have our challenges and stuff, but we're killing that stigma now, and we're saying, "Hey, I'm okay," and we're also saying that everybody has some stuff that they're dealing with in their life. This is just something that I have to over. We're all overcomers. We're all dealing with something. And so we got to kill that stigma.
Yeah, this is Miguel. I fully agree. The stigma part is the part that impacts, and you will see it regardless of the person's ethnic background. You see they have their own level of stigma regardless. I mean, yes, to John's point, the US in a sense is in a little better place. I mean, what's that cartoon that came out not so long ago about the emotions?
Oh, yes. Yeah, I know what you're talking
Oh,
about.
Inside Out.
Inside Out, yeah,
Inside Out, yeah.
even part two. So I've worked with little boys that are autistic, and I've been working with them for 12 years. I do that aside from this. So we were able to go see the movie and then come out, and while we're eating nuggets, I'm asking questions. So what was your favorite part, and what did you think? And they were able to capture. We need ways that are out of the box to really go against a lot of the stigmas that are out there, because some of the stigmas are not even said. Some of it is just, you know what? They may not be said to me, or the language that's used. Oh no, don't tell anybody that you're going to a therapist because you're going to then do something to the family name. Now it became an issue of the family where I am the one that's ruining the family's image, that image that they have in the community, wherever. So it becomes a problem. Or if a person is going to go, a person from my ethnic background may go get services, he or she may want to go to an office that's in another borough so that they don't run into anybody they know, just out of fear that they're going to run into somebody and then have that person go, "Hey, I saw you going into you know this place counseling, and this," then it become then the fear is there. So it is. And then of course a lot of the misdiagnosis where you'll have a child who may have some traumatic events, and then what'll end up happening, they'll stick them with a child that is disabled. Now it has nothing to do with trauma, or they'll take a disabled child and say, "Oh yeah, he has mental health." No, it's disability. It's a physical disability. their brain is working great. They don't have any emotion, but they'll lump them all together, special ed. And they just throw, once of course there's a financial part to that, but once again, they're lumping them together. I do like the idea that they are starting earlier, to John's point, early intervention, CPSE, before 5 years old. So they're trying to intervene early. But then you have a lot of migrants that are coming from across the border, whatever border they cross, and where they're from, they're not as receptive as those that are here, born here, raised here. And even then they're pushing back. But they're not going to come into another country to get mental health services. They're coming here to work regardless, and they're going to try to push through it, not realizing that they're causing a lot more damage to themselves.
Okay, so what unique challenges do people with mental health disabilities face when trying to self-advocate, especially in spaces that may question their credibility or autonomy?
One of the challenges is understanding that because a person has a mental health diagnosis or something going on within inside of them, it doesn't mean that they're not smart. It doesn't mean that they can't think for themselves. It doesn't mean that they can answer for themselves. It seems that people always tend to want to answer or step in for you when you haven't even asked for that help, because you can fully answer for yourself. You can fully move around for yourself. It's not a sign of weakness. It's not a sign of a weakness to a culture. I consider myself a Black Puerto Rican, and I'm very distinct with that. For those that have gone to Puerto Rico, they're fair-skinned Puerto Ricans with blue eyes, and then there are others that are darker than, different shades. But even amongst them, they feel that there is shame and weakness if they declare or if they say they're going through some mental health crisis. It may be temporary. It may be long term that it needs further help. How many women will refuse to go to get mental health assistance after giving birth based on their culture? And if their child is born with a disability, now they're looking at themselves. What did I do wrong for the higher powers to punish me through this happening to my child? There are a lot of stigmas in cultures, within cultures, and in the Hispanic culture or Puerto Rican culture. Just to be clear, I sometimes don't use Hispanic. Spain had the majority of the Tainos, which are the natives from Puerto Rico, as slaves. And when they brought slaves over from Africa, a lot of them stayed and resided in Puerto Rico. And unfortunately, Spain was the main one. So using the phrase Hispanic means that I'm associating with Spain, but no, I'm just a Puerto Rican. And once again, just trying to move forward. But once again, and then of course, if I choose to go to somebody to speak to, a clinician, a therapist, anyone, psychologist, psychiatrist, then I'm really turning my back on my faith. And a lot of people will rather go towards their faith, whether it's lighting a candle in a church, where they're praying in, at a mosque. What they would rather do that than seek the help, not realizing that they may need both. It doesn't say stop. It doesn't mean stop. What it means, continue and keep advancing. John?
I tell you, one of the biggest issues or problems is disbelief. So if I say I'm not really doing well, I'm not feeling well, a lot of people say, oh, he's making an excuse of why he doesn't want to come to work, or, really that depression really doesn't exist, or, and because someone who does not live with depression or anxiety, they can't necessarily relate. So they say, oh, just get over it. If I could get over it, I would, right? So, that's one of the biggest things. A lot of people don't believe that, mental illness is a factor, is something that really exists. I'm glad now that we're getting the research. My brain is different from your brain and different things like that. They're showing that this is a real thing. This is not something that is fictitious or made up. When people say, if I'm depressed or down, I'm like, why are you down? Why you shouldn't be down or whatever. So the disbelief of people who just cannot relate or don't want to relate or something like that is really is a chore sometimes. And I have to say, I can't be concerned about those people who don't believe that I actually have a diagnosis that's real.
I kind of to answer this question, I was thinking kind of three different rough categories of things I witnessed. I like when the Chinese person, and I'm representing the Chinese community. I'm a Chinese therapist. Just to put it here. Um, yeah, I've roughly categorized three categories when the person's trying to seek help. One type is actually no awareness. Then that's also a group who will not seek help. And they are suffering a lot, but they just have no awareness. Their family members have no awareness. So just things just get really bad. So, and then another group, I think, is the group we're more talking about here. Miguel and John are talking about. Like people are a little bit aware, like, I feel depressed, I feel anxious, I feel weird. And then they try to seek help, and then they got met with a lot of shaming, a lot of that's just the phase, you'll get over it, or a lot of minimizing. And some people, like especially in the Chinese community, this a common response would be, "Oh, you feel depressed now? Let me tell you, 10 years ago, when I was going through that, it was, you should just do that." And it may be well-meaning people who are really trying to help, but all of these responses will make the person really hard to continue seeking help. So I feel that's big a big group of people. They are a little bit aware that, oh, something's not great. And they try to seek help, but then met with a lot of bad things. And then there's also I would say another group, maybe people who are lucky enough to have more strength and more resources. They are aware, and then they are seeking help, and they're actually having the courage to face the actual very negative consequences, like everybody talked a lot about here. Like you may actually be isolated. You may actually lose some friends. You may actually not be welcome in certain places you want to go to. And people who are kind of like warriors, really fighting these things, but they want to stay true to themselves. So I feel it's a good place to pursue to be. But at the same time, as a therapist, I also want to say each of us is in each stage for very good reasons, for very valid reasons. So even if a person's in the not aware stage, I think there's also very good reason for that. And I think that's something actually I'll talk more about later. So I will right now give to Christina.
Thanks, Jiwon. So this is Christina. So I noticed that like I broke it down into this self-advocacy into like different parts because I try to think of the personal experiences that I've had. And so when we were talking earlier about the intersections of like the social determinants of health, which I mentioned earlier, to like criminal justice, healthcare, education, employment, these systems that some are very rooted in like biases. So my first experience as a self-advocacy, I can remember when I first got diagnosed, it was in a healthcare system. And I was facing some challenges working in accounting as a woman, where it's predominantly male dominated. And so I had to get hospitalized because I was just overwhelmed and I was being discriminated in the workplace. And I didn't understand that. So when I went into the therapy to the hospital, there was a white male medical director, and I'm trying to, but he brought in a whole team of like school students, and I'm saying, sharing and crying and oh, I'm being this happened to me at work and this happened to me at work. People don't listen, blah blah blah. And instead of like really listening and validating me, he misdiagnosed me with schizophrenia. Like what I wasn't saying was valid, but I knew what I was saying was
Wow.
true. And so he gave me this medication that kind of like paralyzed me because I couldn't move out the bed. And I remember that um I was traumatized in the hospital, honestly speaking. And so eventually, like luckily I didn't want to take the medication. So one of the people in the hospital, like one of the people that look on you when you're in the hospital, I don't know what you call them, patient care or whatever, he told me, if you don't take that medication, you won't be able to leave. So I took the medication, but I knew it wasn't the right medication. I knew it was the wrong diagnosis. So when I came out, I was able to find a doctor, fortunately, a Black male doctor, to talk to me about like what my experiences of living in America as a Black woman. And I was like, okay, I get it. But I still, and then he diagnosed me the right diagnosis, and I still take medication today because I know it's fits for me. My second challenge was basically the criminal justice system, where I was at a friend from college's house, my college, and she was having emotional episodes, but she was diagnosed as yet, and she didn't want to get diagnosed. So her thing was marijuana to calm everything 24/7. And so, but I did notice that she had these very intense anger management mode sessions where she used to like beat up her husband. And I was like, oh, okay, that's not good. And I was like, one day I was like, oh my gosh, she's gonna beat up me. And so happens that one day she got triggered and she started beating me up for no reason. So I called 911, hysterical crying. And the mistake I made, I said, I live with bipolar disorder and I need your help, right? Because I'm thinking that, oh, children and senior citizens, they can get help. So I have a disability. They're going to treat me like they're going to protect me. So when they came in as if I was the emotionally disturbed person, the EDP call, and they sided with her. They took their complaint down. I was like, well, what about me? I'm the one assaulted. Oh, well, we don't got your complaint. We can't take your complaint. And I'm like, but why? But why? I'm the one assaulted. So that's what I realized, that people with mental health were criminalized. So facing from the healthcare, but being misdiagnosed, and then being criminalized in a criminal justice system, I realized that self-advocacy doesn't always work, even though I still advocate because it's very important. But like you mentioned, you and some people are the warriors. I try to be the warrior, but at the same time, I don't want to be the strong Black woman. It's very stressful. It's not a job I signed up for. I just want to be a woman, period. I just want to be a human being, period. Don't label me. I want to be treated with respect and dignity everywhere I go, period.
Mhm.
So the fourth question, how does peer support and lived experience help create truly safe spaces, especially for those marginalized or harmed by the traditional systems?
Great question. And I recently became a peers specialist. I had to take all these modules and stuff like that. And I have to say that, a peer talking to another peer, it's like, it's a language that we have that's understood. So it's very difficult to explain how I'm feeling to someone who's never felt that way, right? But someone who feels that way, it's like, oh, okay, I get it. And you don't have to do a lot of explaining. And my thing is, and I run a support group. One of the things that is really, really good is that, in sharing our experiences, we get it. And so we create a safe space that we could talk about things that we may not, if we're in a group that, never experienced these things, would be like, well, I don't get it, So creating that safe space peer to peer is really, really a good thing because there's support in numbers, and you feel like you're not alone, all those things are really important in bolstering your self-esteem, your I'm not alone. Oh, you felt that way too? Oh, I tried to explain to the other guy, he couldn't understand it. So those things in terms of advocacy, in terms of feeling not alone and being unified, all those things are important in someone who is dealing with a mental health challenge. So I think that's key.
Yeah, I when I see this question, I keep thinking I can't remember how many of my teenager clients who told me they are not killing themselves because of a certain idol.
Mhm.
So idol industry, celebrities, influencers, especially young people who follow a lot nowadays. A lot of them, I know there are many problems there, yes, but one really positive thing in my work that I see is that they really are oftentimes making teenagers feel they're inspired, they can feel good about themselves. I also had one teenage clients told me that because they saw a certain celebrity talk about you don't have to be too skinny, you can have positive body image, and she felt very good about herself too. So I feel that's a very powerful resource to make especially younger people to feel that they can be who they are, and then still feel that they can be themselves. And another thing I want to say is just psychoeducation. Again, because I'm talking about Chinese community, I just feel the lack of awareness is really there. And if there's can be more psychoeducation, especially on not just for the people who are suffering, also for the family members, the friends. Like, how can you support someone who's depressed? How can you support someone who's anxious? So well-meaning people don't have to say the first thing comes to their mind, and oftentimes those are harmful things, and they're the well-meaning people actually don't want to say those things. So so I feel psychoeducation for everyone is something I'm thinking about.
Thank you. I fully hear exactly what is being said because it does resonate in the Spanish community or in any community. And if I want to even take it to the gender, male gender, creating a safe place where they're not going to be ridiculed, where they're not going to be spoken against, where they can just speak their truth and have people not interrupt, just listen, not try to correct, not try to impose their own opinions on them, just allowing that space. And then even following it up with a question, and how does that make you feel? And what are your thoughts?
Mm-hmm.
And and just allowing them, and then asking them, so that's the surface feeling. Let's go a little deeper. What's actually going on underneath that's bringing this up here? So creating that place so to help break that stigma. And the stigma is I have nowhere to go. I volunteered there's an organization called All Kings, and they work with men. They have a woman's component, but they work with men, and they pay, and this is in New York City, they will take the men every so often, men that want to go, they have a space, they go camping. While camping, they share that time for those men to open up and share when nobody's around but trees, and we have to tell them that there are no bears out there and stuff like that, and no lions, but they've never been out there. They've never been out of the city to go somewhere so secluded and have the supports that you need so you can share what you want to share. And nobody is there to try to correct your behavior. We're there to support you and allow you to bring some things out that you normally would feel unsafe to bring out anywhere else. With veterans coming back, and everybody expect you to be okay after everything you may have seen, after everything you may have experienced. And that's even hard. And a lot of the individuals that I've worked with the intimate partner violence are ex-veterans. They come back on high alert, constantly hypervigilant. And now they're expected on a switch to switch everything off and be okay. And when you're standing in key food, somebody cuts you off. What do you want to do? Pick up the cart and hit them over the head with it. And you got to quickly figure out a way to control. And they want to medicate you. No, they should have worked with this person prior to letting him or her go home.
Yeah.
So that they can readjust. The adjustment is not easy, depending on what you witnessed and saw. And even with the adjustment, sometimes you're going to need additional help. Unfortunately, the VA hospital, is losing funding for all this, and it is challenging for a lot of these individuals. Christina?
Wow, Miguel, that was really powerful. I didn't really think about the vets, which is really important because often I mean, for you to serve this country and to come back and not have the services is really unfortunate. It's a disservice to them. So when I think about this peer support and lived experience question, I, you know, I advocate for public health responses to mental health crisis, right? And I believe that peers who with lived experience in like mental health, substance use, people who are unhoused or justice involved should be part of the first responders when engaging people when they're having an emotional crisis, and along with the EMT worker. With peers, as we both all agree that we listen with no judgment. We work on meeting people where they're at. We don't view people at what's wrong with you, but like, really, what happened? Tell me what's happened to you so I can help you through this. This is the kind of support that helps people feel safe, respected, and when talking with peers. I think it's important, like when we need to focus more on appropriate responses to mental health care, because police are trained to do the crime. When you think about 911, 911 has four responses. One is like if you get sick, you get a medical. If you got a fire, you have a fire department. If you get police, is used for crime, and police also respond to mental health. So they got two responses, but police are trained in crime. We need to move away to create a safe space like calling 988 or some kind of mental health response number because people need to feel safe when they get responded to. When we have peers in the space advocating, it's like we're more person-centered, we're culture responsive, we're trauma-informed approaches to mental health care, and we treat people with dignity, compassion, and care, that's what we do. So in 2020, I created the Person-Centered Intervention Training Program in Fort Greene Park, where I hired peers to respond to people who were well, becoming unwell, who were in crisis. This is a way to divert people from the criminal legal system to treatment and care and meet people where they're at because people are in need. If people are having crisis, again, we need to find out what's happening, not what's wrong with them. Is it that because did they lose a loved one during COVID? Did they lose their job? Find those unmet needs, meet people where they're at, and if you help them with those needs, a lot of times they can recover quickly. So the last question is, how can we shift cultural norms to encourage most honest, stigma-free conversations around mental health and disability? John, you go first.
First thing I think about is having forums like this, talking about this, sharing. People just have not having the fear of being ridiculed or having that stigma of, oh my God, someone is going to put me down. The more we talk, the more we share. I tell you, when I give my talks, the first response I always get is, wow, you're so successful. Like someone with mental health challenges are not supposed to be successful, right? The second response I might get, especially since I'm in the community that people might know me, in a joking way, they say, yeah, John, we always knew you were crazy, right? But the third response I get 100% of the time is, me too, my uncle, my mother, my friend, so it's something that is really prevalent in our society. And the more we share and the more we talk, this program I'm doing, Sharing Hope, going into communities and talking about things that they never talk about. And it's such a relief and and they realize that, oh, you too. And I love it in the community conversations because I don't have to even say anything. They start, oh yeah, my daughter, and it's about a community healing and the community kind of healing each other. And I love the fact because they started sharing. So we need to do more of this.
I completely agree. And you already speak about my first point. So I'm not gonna repeat that. So my first point was just to be seen, basically. Like all our fears, the depression, and anxiety, different things people go through just to be seen. Same point. And then another thing I want to say is related to what Christina shared before, which is there are days that we want to be warriors, but there are days that we just want to lie in bed or watch a movie or something, right? Like it's never a responsible or obligation for anyone to always have to be the fighter. So we all have the right to fight, and we all have the right to rest as well. So I just really want to state that. And I think that also relates to my third point, which is self-compassion. And it especially when we're doing this work for people who are trying to promote mental health or trying to heal themselves. I think though if there's only one question a person can ask themselves, I feel a good question is, what do I feel today? How am I feeling today? Maybe I feel happy today. I feel excited today. I'm gonna do some warrior work. Maybe I feel depressed. I feel both fearful and anxious. Then let me take a bath, right? So I feel the self-compassion to really pay attention to oneself and to be attuned with one's own needs of the certain moment of each day. I feel that's a founding stone of how we can shift cultural norms to encourage more honest and stigma-free conversations. So I hope more freedom to everyone.
I always go towards the education, and I know we've been speaking quite a bit about the individual or individuals that may be going through some sort of mental health crisis or need some sort of assistance. But I also think that shifting the cultural norm requires educating the culture, the mother, the father, all the other individuals that are going to be around the person who's seeking support, so that they know what does it look like when what does it look like when I just need to sit next to this person, and what does it look like when I need to call somebody and have intervention arrive, mobile crisis, whomever. So what is that intervention? What does it look like? What does what does schizophrenia look like opposed to bipolar? Why? And because people use bipolar so loosely. Oh yeah, you bipolar. Yeah, you bipolar. Yeah, and understanding that education, which is why I love the mental health first aid, is not to teach them how to diagnose. It's to teach them how to spot some warning signs, some little red flags that make them go, and then approaching, not judging, not coming in with any of your own bias, just allowing yourself to be the recipient of whatever this person may want to share. And they may say a lot without even saying a single word. So it's teaching the community that it's okay to see something and then knowing when to step in and say, hey, you know, one of the toughest questions when I facilitated mental health first aid is when you have to ask somebody, are you thinking of suicide?
Mm.
It's a tough question. And where it was even tougher was when some of those learning the skills, because of their faith and their religion, they wouldn't want to ask that question. What do you mean they want to kill themselves? They're going to go to hell. I said, but that's not what that person needs to hear. You want to be there and ask that question. And what if they say yes? Well, I'm glad you asked that. And then these are the steps that you can follow. And once again, it's being educated in what to do, what not to do, what to see. It doesn't mean that you go out there and try to diagnose, you're going to see something in everybody, because you might. So, but you're not there to diagnose. You're just to be educated, to see something that is all out of the normal. And then how do you assist this person in finding the supports that they need? All of them don't need to go to a clinician. They might be able to go to their religious leader. It looks different for everybody, and being okay with that.
Thanks, Miguel. So when I think about the shifting of cultural norms and having a conversation which we all brought up, I think about language because language is powerful. Think about the terms, the derogatory terms that people may call all of us on the phone. Black male, Chinese woman, Puerto Rican male, the language that we use to describe each other in a derogatory fashion. So we know, like in our community, they call us crazy and the whole dangerous. Well, most of the peer community. I'm not sure if people identify as peers in this call, and it's just like people are not humanizing us. And so we need to learn how to use more respectful terms to be more respectful and humanizing. I know, Miguel, you work with people with developmental disabilities. Is my correct? Is that the correct terminology? So I remember back in the days we used mental retardation. Well, that was heavy. But because of Rose's law, they changed mental retardation to people living with intellectual disabilities, which is more humanizing language. And
Absolutely.
this is what I feel about like the terminology when we talk in the criminal justice system, EDP, emotionally disturbed person. That's very not person centered. It's not person first language. It's not people living with. It's that we're EDP, which is dangerous and crazy and deranged. And if you read the patrol manual, you would see that. So I went to Assembly Person and I asked for language change. So right now it's been introduced from changing the language of emotionally disturbed person to people experiencing an emotional crisis. So we have people first experience an emotional crisis, which is person first, trauma informed, person centered, culturally responsive language that makes it's more humanizing language. So to me, language starts there. It's about changing it to be more positive. But not only do people use the EDP in the criminal justice system, they use it in the clinical, they use it in schools, they use it in hospitals. So when you get the 911 call, it goes EDP to every single system. Now, if we change the language as a person experiencing a crisis or peace, they'd be like a person, we have a peace call, please go to with the peer response, right? Help this individual see what services they need. And if you have to transport them, you take them to a hospital, to a respite center, to a clubhouse because they need the support. Just avoid going to the criminal justice system, right? So this is more of a public health response, but it starts with language first. And this is important to me because we start at the home, like we mentioned earlier. We start at the different systems, then we get all normalized mental health, and no one would be afraid, and the stigma would just die down. Any other remarks? Because that's all I have.
I just want to say thank you for this opportunity because I love the fact that different ethnicities and cultures were talking about the same thing, right? Different experiences. You hit the nail on the head about language, right? It's important that we change our language about. I mean, I even had a talk with the head of the National Alliance of Mental Illness, right? The big boss. And I said, we need to change that name. Could be National Alliance of Degrees of Wellness, right?
Yes.
Little thing, because illness itself is like, oh, he's ill, right?
No, it's not even recovery. When you say
Right, something in the more positive because our language shape, and I think Miguel mentioned it as well. Our language shapes our lives, and it's important. So I'm glad you guys spoke on that. We need to change, be more positive about things, more uplifting, and things will change. So I thank you guys for this opportunity. It's cool.
I really enjoyed this talk. I mean, any of you, Christina knows if you need my support with something, show up or whatever I'm here.
Cool.
We just gotta arrange my schedule, but it's what we're here for because on the other end, those of us that are assisting others, we need to be able to unpack as well.
Yes.
You can't just keep taking all this in and walking around with all this baggage and think that it's not going to affect you one way or another. So we need the support of our peers, those of us that are in the trenches, military, or those of us that are doing what we have to do to just even go out, even if it's to sit in the park, a Broadway play. Self-caring extremely hard together is important because it's the only way we're going to remain effective to those that are depending on us. And if any of you need support,
Amen.
Once again, don't be shy because you don't know if something that you need, a resource or something, one of us can step in and who knows.
Absolutely.
Yes,
I got
yes.
no mistake. All right.
Thank you, guys.